Well, we had a really good MIS session. Roger Kern Bay, thanks so much for sharing all the insight and knowledge for our fellows and everybody else on the call. So I think, Chevy, we're going to combine now. Is that?
Yeah, we're going to combine. And I think basically just wanted to see the themes that got touched on. Hanjo presented this case, which I thought would be interesting for you guys to opine on also. Hanjo, I'll let you present it. Go ahead.
So basically, this is a 62-year-old lady who had this operation done at an outside hospital a few years ago in 2015. And she noted basically in the last couple of years progressive dysfunction with ambulation, standing for a long time, with severe back and buttock pain. It gets relieved when she lays down or when she sits. But when she's standing or walking, she finds it really debilitating and is now thinking that something's wrong with her back. She actually went back to her prior surgeon who did her surgery in 2015, and he said, "Oh, everything's fine. You're fused. I don't know why you're having back pain." So she basically came to my office with these images. Next slide. So you could see here, those are the standing x-rays on the supine x-rays. Just to give you guys some context, she has a pelvic incidence of 75 degrees and her lumbar lordosis is 61. So if we look at that 14-degree difference, not really horrible as far as thinking that it's a flat back given a 62-year-old lady. But if we look at the segmental lordosis from L4 to S1, we see a 21-degree lumbosacral lordosis there. Next slide. She also has some central stenosis at the L3-4 segment. And also on the prior standing images, you could see a grade 1 spondylolisthesis at that segment and some central stenosis there as well. Next slide. Next slide. So, I guess we wanted to talk about this case because we thought maybe the MIS folks would have some insight into approaches for this, given the parameters here. So maybe Shiraz will open it up to the MIS mavens over there to see what the thoughts are.
Okay, yeah. Why don't we start with Kern? Why don't we start with you because you look like you're imminently going to have to go start operating.
So this is where I get to the point, like, I need to understand a little bit more because deformity guys, all of a sudden, they want to justify, like, T2 to pelvis on this case where, what is the patient's real problem? Is it neurogenic claudication? Is it what? Like, sometimes I think that a smaller procedure here is better. So can you give me a little bit more insight into that, Hanjo?
Yeah, Kern. So this patient basically clinically demonstrates flat back syndrome.
Okay.
She has pain when she's standing, pain when she's walking, limiting the ability to walk any sort of functional distance that's compatible with having some level of quality of life.
Can we go back to the plain films?
Yeah. These are the plain films right here.
Does she have neurogenic?
Oh, yeah, I got it. And is it do you have a CT scan? Is it fused in between those segments?
She's solidly fused from L4 to S1.
So this is the first. I'm the first to tell you because I see a lot of bad MIS deformity, a lot of bad MIS, and we end up fixing it. And when you have SVA greater than 10 centimeters, that's a problem. That's a challenge. That's like a very hard case to do purely MIS. You see guys, and what they end up doing, particularly at upper lumbar levels, is they start doing laterals, and then all it does is distract, and it ends up kyphosing those segments even more. So for me, in this case, this is a case that requires some kind of open osteotomy posteriorly. The question is, can we make this case easier? And I think you can. And I think that the way you make the case, it's very favorable anatomy in that if you look, it looks like she has some kind of lytic defect or a spondy at 3-4, which makes it a little bit sloppy. So for me, it is sequential 3-4 and 2-3 pseudo ACR. So I do an anterior to psoas approach. So I do a wide release at those levels, and then I see how much I get back. And depending upon that, then you can determine levels. So for me, it would be a focal correction at those levels. And I understand that her deformity is not necessarily at that level. Iatrogenically flat back from 4 to 1, which is the problem. But sometimes just doing a simple, not simple, but a less invasive approach hybrid gives you a better intermediate result.
Andrea, does she have stenosis or on MRI? I missed the axial cuts. No real stenosis, right?
Yeah, she does have a little bit of stenosis. I would say moderate, but the thing that's misleading about it is that you could see that she has a little bit of a spondy at 4.5, at 3.4 here. On the MRI, when she's supine, it's reduced. So I think when she stands and there's a little bit of listhesis here, the stenosis is probably a little bit worse when the patient's standing, but I still wouldn't say that it's very severe.
Got it. And I mean, she has no lordosis from 4 to 1. So Kern, so from an MIS perspective, do you think you would just get everything back between 2 and 4 with your 2, 3, 3, 4 lateral surgery, or would you still do sort of a midline opening below posteriorly and try to do an osteotomy and sort of do sort of a hybrid MIS open?
This is where deformity guys will slam me, because I'm the first. I concede up front, like Hanjo said, 4 to 1 is flat, and that's where all our lordosis is. So I'm creating an unnatural kind of lordotic segment at 3, 4, and 2, 3. And I actually like this spondy and moving. That's where an ACR is very powerful here. So I would do a full-on ACR at 3, 4, and 2, 3, and then hyperlordose those segments. Overall, getting like 2 to 1 more bounds, but understanding that my 4 to 1 segment is kyphosed, and that's where her problem is. So I'm doing an unnatural correction on her.
Harmonious, yeah, I would probably just do 3, 4 if you said, hey, if I was going to tackle this. And, the SVA certainly bothers me, right? That's the real issue, is the SVA. And, I don't know. I mean, it depends on how old she is, but, the other option is a PSO, a full PSO. And definitely that I would not do for myself. I would send it to Hanjo or somebody else, one of our deformity guys. But I think it's very focal. If you really do a good ACR, you can probably get 30 degrees, but you have to do a PCO in the back, right? You've got to really take it down and just got to see where you end up. But, this is something you want to plan to see if you could get there. And I think if I could reduce the SVA, then I'd be happy, agreeing with Kern. I mean, because your other options, I think, are, certainly more morbid.
What do you think, Roger?
Yeah, I still want to know what her symptoms are, because she's got pretty significant lumbar stenosis. So if I get the sense that she really has symptoms going down into her legs, then I think the whole idea with the deformity correction becomes much more complicated, because it's impossible to predict how much of her SVA is because of her leaning forward to compensate for the stenosis, because she's got pretty significant stenosis versus a true deformity. So I'd be very careful about that. My sense is that if you do a decompression and extend the fusion 1 or 2 levels higher, maybe do an ACR to get a little bit of correction, that's probably all she needs. But the stenosis, in my opinion, was pretty significant.
I mean, the other option, obviously, there is a PSO, right? But that's definitely a different option. So it's really, can you avoid the PSO by doing the ACR and doing a good decompression in the back and trying to do it focally, even though that's not really what we would call harmonious lordosis, right?
I mean, her films look worse than her numbers.
It's interesting. First of all, Roger, you don't need to know her symptoms. You have an EOS. Deformity guys don't talk about symptoms. They just look at balance. So Hanjo had to look up the record to see what the symptoms were, number one. Number two, I see ACRs done percutaneously at the back, and you don't get the correction. So an ACR for me on this, I go back to what Bay said, and I agree. It requires an open vasectomy on the backside to maximize that, I will say, non-harmonious lordosis. I do the ACR at 3, 4, and I kind of get a feeling as to where she's at. But I'm not fearful of doing something at 2, 3, because my goal is to do as much as I can to stop at 2. Because then the whole thing changes. You got to start going up. And you start chasing dominoes on this case.
Hanjo, what you got to do?
Next slide.
I can picture the post-op.
So actually, next slide. So what I ended up doing, let's put this on record. I actually did a more minimally.
Love it.
Oh man!
So I didn't even extend this patient to L2. I just went to 3. I did an L5 PSO, and I just want to go on record by saying that I did more of a minimally invasive surgery as far as levels and preserving free motion segments for this patient than our MIS maven here, Dr. Singh.
Look at this.
You forgot a cage there, though.
I'm speechless.
You forgot a cage.
Yeah. Well, the L5 PSO, we got bone-on-bone contact, so.
Oh, at the level above, right? There's no.
Oh,
Well,
a
you
3-4.
know what? That's
good.
Looks great.
Phenomenal job, Hanjo, on this. I mean, it's a good thing that 3-4 was so sloppy. I mean, that's the play. That's why you got to look at that one. But
Well, the other thing is that when I think about it, L5 PSO, just an isolated L5 PSO, I mean, how much blood do you use, Hanjo? Probably not much.
Yeah, no, we got, I think, like 700 total for the case.
Listen, I mean, we just kind of pass off and say L5 PSO and ACR are easy procedures. Neither of these are easy procedures. So, I'm not attempting a PSO at this stage in my career anymore. So I don't have that. I don't think I have that ability to do it in a thoughtful manner. But the X-rays look phenomenal.
Yeah, but I got a question for you guys. So, I mean, I was, first of all, really impressed with the MIS attention to, like, the harmonious lordosis. So my question is, like, if you had somebody in your staff who's willing to do a PSO, and you know that if you do an ACR for this patient, it's a non-harmonious sort of distribution of lordosis, wouldn't you just then send this patient to the person that does the PSO that they could have the operation that will result in a more harmonious correction and sagittal balance?
Yeah, no, I agree. That's why I said that. I said that the controversial thing I'm going to get slammed for is harmonious lordotic correction. So, the problem here was, as I said earlier, is 4-1. I see so much bad MIS deformity that it makes no sense to me. Someone adept at doing an L5 PSO, that's the right answer. That's where the pathology is. Yeah. The challenge becomes oftentimes, though, and this is not the case, but oftentimes I see that people justify T10 to pelvis on this case or something. And that's where I'm saying, no, that's not an option. It should not be an option. Right. But for this is the perfect solution.
Yeah, because, I mean, doing a T10 in the pelvis here, I certainly think can be justified by the deformity guys, for sure. Yeah. Like if I pass this around to our deformity guys, we would probably get at least one of them saying, look, we need to go to L2, but it's going to break down. We should just go to T10 and be done with it, right? So, yeah, but I love this. I think it's great.
Looks
interesting
awesome.
discussion.
Yeah. Hey guys, any thoughts around if you did like the hybrid sort of, do just a traditional XLIF, not an ACR, turn the patient over, and then do like a mini open PSO just at the 5 level, so you're only opening up L5 and not opening up everything? Do you guys have it? I haven't done them, so I don't have any experience with it, but I know Mike Wang talks about it. Kern, I don't know if you've done them.
Well, I've done a percutaneous PSO. I mean, I've done tubular. So criticism I would have would be, so I would have started lateral and I would have done the ACR or a release or a lateral cage, because it costs you nothing and it gives you a nice support and it eases up your fusion on the top part and it just kind of locks everything in. But I would see also 3-4 ACR, 3-4 lateral release, what I got, and then to see what we needed at 5. Now, when you talk about instrumentation and talking about opening things up and doing a tubular pedicle subtraction osteotomy, which we've done, it doesn't make sense because the instrumentation has to be opened up. So it's more just to do it just to say you've done it than it does like re-instrumenting and doing a good solid fusion posterior laterally. So I think it's just more for show than it is actually accomplishing of any work.
Yeah, I didn't realize that was your question. I thought you were asking to doing an ACR at 3-4 with some type of posterior disc distraction and somehow releasing the ALL from posterior.
No, I was talking about, again, I haven't done them because we have, amazing between Frank and Hanjo, they're such great deformity surgeons. So, but I know, it's published and I agree. I think it's probably sort of unnecessary because at that point, I don't think you're saving much. So.
All right, guys, we'll stop it there. We'll move on to the next session. Thanks. That was a great case. Looks awesome.